I'm delighted to introduce Cris Ross to give us a keynote address. He is the Chief Information Officer of Mayo Clinic. He's on the board of HIMSS North America, eHealth Initiative, and Zipnosis. He works as an advisor to HL7 and Project Argonaut, and has participated in work groups for the AMA on EHR usability, the AHA on interoperability, and more. Prior to joining Mayo Clinic, he held technical and business leadership positions with SureScripts, CVS Minute Clinic, and United Health Group. We are so thrilled to welcome Cris to the Health 2.0 stage for the first time. Welcome, Cris. Thank you so much.
Thanks, Indu. Well, good afternoon, everybody. I always like coming to Health 2.0. I've been coming here, I think my first was probably 12 years ago or something like that. So they invited me to speak here, and I thought, great, that sounds very nice, thank you. They said it'll be easy. You just give a nice half-hour talk. What they didn't tell me is you're going to follow a succession of panels of people who are doing heroic work in healthcare, who have inspiring, amazing stories, and I get to follow them. So I thought I liked Health 2.0. We'll see how we do. So in response to that, I'm going to try to really bear down here and give you 30 minutes or so of interesting ideas. What I might do is to expose you to something you didn't know before, but this is a pretty smart crowd, so I doubt that. What I might be able to do is to give a perspective from a particular angle, a guy who's a CIO at a complicated healthcare system, and what we're trying to do to solve some of our toughest problems. That might be helpful. And third, I'm going to share a little bit about Mayo Clinic's specific approach to these kinds of problems. Where are we right now and where are we going? And hopefully that might be interesting. So let's start with this question of building health systems that work for patient and provider. What are those attributes? And this is the audience participation portion of my talk. Consider yourself cued. I'm going to break the rules and ask people to just shout out stuff in a minute. I want to ask, what is it that we are trying to do with these health systems, to make them work, to work for what purpose, for what goal? And there's maybe some obvious ones, which is, triple aim kind of goals. Improve the experience of healthcare, reduce the cost of healthcare, increase the health of populations. It's pretty straightforward. But what about for providers? For providers, they want to know that they have meaningful work, where they are operating in an efficient and effective way at the top of their license, that they're delivering the best treatment that's appropriate for this particular instance. But they're also looking for joy in practice. Being a provider is hard, and we make the bar even harder with providers by layering on for them unbelievable levels of complexity and regulation, which makes their work incredibly hard. We have to help them with that. We want to try to find a way to bring some joy back to their work. What about patients? Patients obviously want to have better cures, lower cost of care, but they also want to have a consumer experience increasingly. They want to think about healthcare as something like what they consume someplace else. They want to know that they are getting the best kind of care that they can for the particular problems that they want to address. And then they want to do something new that I think has emerged just in the last couple of years, although you can see antecedents going back decades. Patients now understand that as they are treated, information about them can be used to help other people receive a cure, right? So I've spent most of the last year being a cancer patient. I'm in good shape now. But I'm very eager to share my data so that the next cure can be found for the next person who's behind me. So I signed up for 3 clinical trials as part of my treatment, and I would sign up for more because more data drives more cures. So that's what I think people want to make a health system that works. A system that works would have those attributes, the kind of system-wide outcomes, ecosystem-wide outcomes that I talked about at the beginning, but also the experiences for the people who are in those systems, the provider and the patient. So what did I forget? Is there anything that's pressing that should be in these health systems that I did? Resilience meaning what? Avoiding disease and illness. Prevention, resilience, that's a perfect idea. There's one I did leave out, which is I work for an academic medical center. Part of what we are trying to do is to pursue the next generation of cures. So our providers, in addition to treating patients, they also want to do research, and they want to develop a next set of cures, and they want to think about how to avoid disease. All right, so maybe we have consensus around what kind of system we want to build in general. Let's talk about what we've got right now, because to get to where we want to go to, you have to know where you're coming from. So, most corporate systems are systems of display, record keeping, and workflow, right? Whether I am a stockbroker or a lawyer, a reservation clerk for an airline or a hotel, or if I'm a physician, mostly what I do is I want to look up things or have them presented to me. I need to enter some information. Sometimes it's really simple, sometimes it's really verbose, and I want workflow. In the case of a doctor, I want to issue an order, I want to make a prescription, I want some action to be taken, and so on. So pretty straightforward. Now, I would make the argument in a provocative way that the systems that we have in hospitals today are about as good as corporate systems you would see in another setting. Now, some of my doctor friends at this point would want to put me up on a stake or tar and feather me. What in the world are you talking about? Well, let's explore the issue a little bit. So I put up on the screen here not doctor's context, but context from other places. In the upper left-hand corner is a workstation of a trader, someone trading equities on the stock market. In the upper right-hand corner, the bearded fellow is a CPA with his 3 screens managing his cases. In the bottom, that could look like a screen that you might find in Cerner or Epic. It's really a case management tool used by lawyers to manage their workflow of legal cases. They all look pretty much the same, frankly. They are all performing basically the same function of displaying information and so on, right? Basic kinds of things. So why is it then, if this proposition is maybe true, that providers are so completely frustrated with the kinds of systems we put in front of them? Well, let's talk about the complexity of the healthcare setting compared to other places. So imagine, if you will, if we took the healthcare context and we put it into typical corporate kind of setting. Imagine you all came here, and many of you have checked into the hotel here, and the experience was probably pretty easy. Well, imagine if we ran hotels like we do healthcare, and healthcare was paid for by a healthcare provider, and you show up at the counter and find out that your requested upgrade to a junior suite required a pre-authorization call. And the clerk was going to have to call your corporate travel office and make sure that you were eligible for that junior suite. And they make that call and they find out that, in fact, you're not. And your minibar privileges have been revoked last month because of a change in benefit policy. And then they ask you for a check for $15. And then a month later, you get an explanation of hotel benefits. And at some point later, you get another bill for $150. That's the way it would work if healthcare came to a hospitality setting. Imagine if you were going to your lawyer, asking that lawyer to help you negotiate an employment agreement. Well, in that circumstance, perhaps the lawyer would require your last 3 years of performance evaluations in standard format, would need to understand what all of the measures were of above expectations, meets expectation, below expectation, mapped against some sort of vocabulary code in some sort of fashion. And then your employer would be required to submit these to your lawyer, and if they didn't, they would be found in violation of information blocking requirements. Right? So I'm being absurd on purpose. The point is that the complexity of healthcare is at least an order of magnitude more complex than other kind of information settings. And that's largely the reason why we run into these frustrations that corporate kinds of systems brought to healthcare represent. So, what are we going to do about it? Well, there's lots of ways that we can improve it, And we will, over time, continue to evolve them and continue to manage them. But at its root, we have to remember that a lot of the systems we're using in healthcare are serving the purpose not of the physician or the patient, but of a broader organization, right? As my brilliant CMIO partner, Dr. Steve Peters, says, the slave will never love the pitchfork. And the reason is because these corporate systems bring with them every government regulation, all the requirements of all payers, all requirements of all quality organizations, all of the policies of that organization, and all the required procedures. No wonder doctors hate electronic health record systems. They are presented essentially with all of the gags and weights and controls and fetters that makes their life difficult. And we haven't been much better at presenting better alternatives to patients in that kind of setting. So that's part of what's difficult about the systems that we have today for providers. What about systems for patients, and do they work? I would use my own experience as a lens. All of you have experience of being a patient. It's all, everyone has their own story. I would say my story of receiving medical care at Mayo was exemplary. Come on, it was Mayo Clinic. I had a great patient portal. My doctors talked to each other. Data exchange was not a question. I would walk into an office and different things would be anticipated. I want to acknowledge the fact that I'm coming from a place of extraordinary privilege, but from that viewpoint, I could see a number of places where we're just not good enough. Number one, I started to be treated for my disease about 2 months after we had converted our EHR in the setting where I was at, and I could still see the bumps and bruises. I could also see places where we had interposed processes and methods to make up for the shortcomings of electronic systems. I also tried to imagine myself, what if I wasn't in this place of incredible privilege? You know, my oncologist is not just a specialist in colorectal cancer, the particular cancer I had. He was a subspecialist in one kind of colorectal cancer. I think about a friend of mine, a physician who treats breast cancer, who says if she reads the literature, there are 17 new novel treatment opportunities that expose themselves in the literature every month. And she's hard-pressed to keep up with it. What about the general oncologist in a community healthcare setting who's treating a wide range of cancers? How in the world can they possibly keep up? So as a patient, I experience the fact that our systems are not adequately supporting our doctors in lots and lots of ways, primarily because we're still struggling with this basic system of automating healthcare and not advancing it further. So we have a long way to go. So what's the next generation? Where should we head? Where are we headed? Generation next ought to be systems of intention, insight, and cognition. Systems that know what we want, that help us see what we otherwise wouldn't see, and help us think, right? That is where we are headed next. And I want to talk about some categories of this and examples for it. The first of it would be systems of small artificial intelligence or small machine learning. And I'm a huge fan of small AI because of the way that it accretes into different kind of solutions. So let me give it a trivial example. You'll all relate to this. I work primarily in Rochester, Minnesota, and I live in St. Paul, Minnesota. That's 90 miles away, and I drive that route some days, but not every day. I keep an apartment in Rochester, and I stay there sometimes, especially when it blizzards and things like that, like it does in Minnesota. When I get in my car and I plug my smartphone in to Apple CarPlay, the car tells me where I'm going to go, more likely than not. How does it do it? It's clearly reading my calendar sometimes, but it's also managing my patterns. It's guessing where I want to go because it's learned about me over time. I don't text when I drive. That's not a great idea. But I can dictate, and I can have the texts read to me because voice recognition nowadays works, right, in fundamental kinds of ways. Car assist keeps me on the road when I get drowsy, driving home at 10 o'clock at night and the road is dark. There are a significant number of systems that impact my life all the time, little AI, that keep my life functioning well. And there are all kinds of ways that we can bring those little tools to healthcare in exactly the same kinds of ways. How can we use voice more than having to have a physician deal with a keyboard and a mouse to provide information? So little AI, big fan. Then there's big AI, the kinds of things that will help us do things like drive diagnosis and more complex things. Now, people think about the possibility of AI replacing doctors, and that isn't going to happen anytime soon. In a minute, I want to give a couple of examples of what I see as emerging stuff that has lots of possibilities. But there are ways in which computers will improve healthcare because they can learn and think for us, and they can discern things in better ways. But before I get to the specific examples, what are some of the implications of these systems of intention and insight and cognition? Well, one is that the way that they operate is very different than the older systems we have in terms of the way we store data, in terms of the way that they function in asynchronous and synchronous kinds of ways. And frankly, almost all of these larger systems with more power and capability to them will not fit and should not fit in a corporate data center, which means things are going to run in someone else's environment in some way, either software as a service or where there's ability to exploit some other system. But what also is necessary in the example that I gave, the very trivial one, is that the system needs to know more about me. These systems of learning, these systems of cognition, depend on intimacy with the people with whom they interrelate. I have to share personal data about myself if these systems are going to function. I also am depending on lots of you all sharing your data so that those algorithms can serve me, right? So there's a collective aspect to this, but there's also a fear of privacy component to this. Now, I guess I care about my browser history being used by somebody. I guess. Mine doesn't happen to be particularly interesting. But there's ways in which it's used to develop an algorithm that helps something for me. I don't mind the fact that a Siri or an Alexa is listening to my voice and learning from my voice because the system works better because it's listening to all of us in certain ways. There's a creepy factor, for sure, in the way the data needs to be used. But the fact is we will not be able to progress in these areas unless there is ways that we can aggregate more data for higher purposes. Again, more data means more cures, and by the way, it also means a better patient experience. So what that means, ladies and gentlemen, is for all of us, we have this fundamental problem. We need to be able to make data liberated and more liquid so that it can serve higher purposes, but we also need to keep patient data private. And I would make the argument that those two are not mutually exclusive, that both are possible to do. It simply depends on integrity, consistency in how we manage the way the data moves between different environments so the data is effectively de-identified and remains de-identified. But these next generation systems are what's necessary for us to get to a new place. So I'm going to now switch a little bit to Mayo's formulation. How are we approaching these problems? We just implemented a giant EHR conversion project. It took us about 4 years. Enormous project. By all the objective measures, we did just fine. But we're also in a place where our doctors are frustrated and our patients are not seeing a particular difference by us doing that. And there's much more that we need to do. So our agenda looks like this. It's probably an agenda that could work in other kinds of areas as well too. 3 parts: cure, connect, and transform. In cure, the idea is what can we do to advance where our focus is on the treatment of complex and serious disease. And there are many dimensions in which we could run and intend to, but the one I want to focus on is what can we do with machine learning and other kinds of systems that will advance cures. Now, I gave a talk at the HIMSS conference 3 years ago with a colleague where the title was, basically, is this AI stuff for real? And 3 years ago, a lot of people said, no, this isn't coming to healthcare. It's all science fiction. Doesn't mean anything. And I think that things have changed enormously in the last couple of years. So let me give you some examples of research we're doing of importance. 1, atrial fibrillation is a disease that somewhere between 3 and 6 million people in America have. Why 3 to 6 million? Well, part of the issue is it's hard to diagnose. So we just had a paper published in Lancet last issue that took 2 populations, one of which was patients known to have atrial fibrillation. This is a disease that expresses itself only occasionally. You can't, people aren't in an atrial fibrillation situation all the time, just occasionally. So there's this population that's known to have it, a population that is known not to have AFib. And the challenge was, can we discern those 2 populations and create a predictive tool? Because AFib can have some negative kinds of effects. So they took the ECGs of the normal population, and then they took the population of people who were known to have AFib, and they took the sections of the ECG where there was an AFib event, they took them out, right? So they were comparing the population when they otherwise presented normally compared to a population that was normal. And they took several 100,000 of these images, applied them against each other, and used machine learning. And it turns out that the machines can in fact discern between the 2 populations. And they can predict who has AFib based on what they were able to learn. So I asked one of the principal investigators, what is it in the waveform that predicts, or tells the difference between the 2 populations? And the answer was, we don't really know. We don't really know, but the machine knows and can discern it. Now, they have some hypotheses about what is happening from a physiological standpoint. The doctors aren't turning the keys over to the machines to make the decisions for them. They're making these biological discernments about this is probably what happens in the atria that creates atrial fibrillation, and we think that the ECG is probably picking up that part of the pattern, and that's what the difference is between the 2. Angiograms. About 1 million are performed every year. Machine learning is now being used to be able to see defects that are not otherwise seen. We have a researcher working on something that he calls radiogenomics, which is discerning the genomic type of a tumor in the brain to discern between different kinds of glioblastomas. And it turns out that a machine can discern that there's a difference in texture in the tumor when a certain form of DNA methylation occurs in the tumor, but not in another kind. So we have the ability to discern that this is a particular type of tumor that might benefit from this kind of treatment as opposed to a different type of glioblastoma, just by doing image analysis, which helps to avoid a biopsy. 2 examples that are useful to me. Again, I've been treated for colorectal cancer. There's about 17 million endoscopies done in the US every year. We're using some machine learning techniques, and I signed up for this clinical trial that will help understand what the right level of sedation should be for the patient to get to a good outcome. What kinds of activities should the patient engage in so that the preparation for a colonoscopy is effective, so that you don't have to go through the cleanse twice. And then also using vision analysis to be able to see lesions that are otherwise not visible to the gastroenterologist who's doing the exam. A final example comes out of radiation oncology. About 1.7 million people get cancer every year, and about half of them have radiation therapy. I had 25 sessions of radiation therapy last winter. And part of what the radiation oncologist needs to do is to understand where to aim the radiation to get the maximum number of grays delivered to a tumor without damaging adjacent organ systems, right? And so the way that they do that is with this somewhat painstaking, mostly manual approach to contouring the organ, to understand where is the organ, where is the tumor, where are the adjacent pieces, and then from that give instructions to the machine so that it can be precise about where to deliver the dose. We've been doing some research in how to do that better so that we can deliver more radiation more effectively to a tumor with less damage to adjacent organs. And, by the way, provide the radiation oncologist with some alternatives. Instead of simply looking at one pathway, be able to compare multiple pathways for how that might be delivered, right? So I hope I am convincing you that this artificial intelligence stuff is for real. Most of this stuff is on a spectrum somewhere from discovery to translation to application. Most of it will have to go through an FDA approval process, which we are all learning how to do. Getting an algorithm approved by the FDA is somewhat new territory, but it is coming quickly to care setting near you. So that's one slice of what we're trying to do around cure. Again, I'm the CIO guy. If one of our physicians were here, they would give a bunch of other examples of how we can pursue cure, but clearly technology is going to be a piece of it. What about connect? Connect is the idea of how do we create a better experience for a patient. Again, going back to this notion of systems of intention. We do fine today in presenting information to a patient. You can go to a portal for your favorite EHR, and they're pretty good products, to be honest. They're just fine. They're comparable to what you get if you go look at a bank or a credit card kind of website. But what they don't do is to effectively communicate to your provider and to the larger entity which supports your provider what your intentions are. It's also pretty lousy at doing what you really want to do. Not many of us really want to download and manage our own information. The roadway is littered with broken hulks of personal health records that went nowhere. Why do we want to go down that road yet again? Instead, what we want is systems that anticipate what people need so that data can be available when it is needed as opposed to on sort of a proactive basis. There's a zillion things we can do to improve Connect so that any door that a patient walks through is better. I also think about the experience of my mother, an octogenarian for whom I manage care. She wants a very traditional walk through the door and physically see the doctor. My millennial daughters would prefer, of course, to get all of their health care on their phone if they possibly could. And health systems are struggling to meet both of those modalities. Finally, transform. I would make the argument that there is not a healthcare organization in the US that should not transform or be an engine for transformation in some fashion. We all can recite the reasons why healthcare in the US is broken and can be improved. This isn't a job for incremental improvement. This is a job for more or less revolutionary change. We have a particular viewpoint about what our next stage of transformation is going to be, and part of that is to configure ourselves as a platform company, where we put together people seeking cures with people who have cures. Medical device, pharmaceutical, new procedures, population health, whatever those solutions might be, to connect them to people who have differential kinds of medical needs, with a focus on complex and serious disease, because that's what we're good at. Other people will focus at other things. And to do that, we want to mediate that in a digital fashion by creating a platform for exchange between those two sides. That's the next generation for Mayo, and we're going to be making more direct steps in that area. How are we going to do that? We made an announcement last week that we entered into a 10-year partnership with Google to help advance this. What are we going to do? Number one, we're not giving our data to Google. We are putting our data into a Google Cloud container where we own the keys. The private patient data will remain private. And we have spent literally years negotiating this agreement, and we are confident that we have the ability to keep that data private. I would also say parenthetically, we know that we can keep the data more secure. It is very difficult for me to defend our resident data centers. Our data centers are fine. They run about as state-of-the-art as you can, but they are connected to a whole bunch of infection vectors, like medical devices, and human error, and we run a very open environment with lots of researchers and so on, and people come in and out for our campus, and there's an opportunity for malicious or non-malicious problems. The data in the Google Cloud is going to be more secure. The second thing we're going to do with Google is to put their AI engineers next to physician scientists to hypercharge the number of machine learning and AI projects we can pursue, and to advance diagnostics and things like clinical decision support. As of today, we have somewhere between 200 and 300 AI projects going at Mayo. Why shouldn't we increase that tenfold? So it's an exciting new frontier for us. My good friend Ashma Gupta from Google is going to be speaking here, I think, tomorrow. And she'll be able to give you a lot more insights into what Google Cloud and Google Health are all about. But we are extremely excited about our partnership with them. And here's why. The technology that we implemented as our system of record, our standard things that we use for care, that we will continue to use for care for decades, is pretty good, but it's not even close enough to the challenge. You know, I'm sure that I run into people from time to time who want to invent the next EHR. They want to replace the EHR. And, you know, the incumbents in place right now will not last forever, and eventually someone will rise and take the place of the incumbents. That's fine. But it's largely a solved problem from my perspective. We don't need a new EHR. What we really need are these systems of management of complexity that can sit between the inherent difficulty and complexity of healthcare and the crazy ways we pay for it and administer it, by the way, and the experience of the provider at the point of care as they are struggling to manage to do their best, and with the patient who is confronted with an incredibly complex healthcare system. And all they want is to stay well, to avoid getting ill, and if they do, get the right kind of treatment with the right kind of convenience at the right kind of price, right? So the next frontier is around thinking about systems that are much more powerful than we have ever had before, because the problems keep getting harder and harder and harder, and the opportunities are in front of us. So not just for our system, but for all systems, there is a very bright future if we are able to walk down these pathways collectively. So hopefully that serves somewhat as a call to action. I couldn't be more fired up about what we're doing, and I imagine that many of you have solutions that fit into this kind of space and can help advance us. It's great to be here at Health 2.0. I know that the next thing on the agenda, I believe, is cocktails, so I will step out of the way. Thank you very much.